All right, take it away, Justin. Thank you.
Thank you so much for that introduction. I put in a request to screen share.
I think I just allowed it, so I think you're good to go. You can go ahead and do that, and then I'm going to stop screening mine here. Maybe that will help. Maybe that will solve the problem here. Perfect.
And then we'll be good to go. Perfect. Okay, cool. So my name is Justin Lorentz. Thank you very much for that introduction. I'm a genetic counselor. I also work at MedCan, a private healthcare facility. Um, Nowadays, but it's definitely still affiliated with the Sunnybrook program. Um, so I follow registered about almost 1,000 men in a registry, and so therefore had a conversation with at least 1,000 men about BRCA or other genes that are related to hereditary risk. And so I guess just by factor of exposure, I've had a lot of exposure to talking with people with genetic predispositions to things like prostate cancer, with the bulk of those individuals being BRCA carriers. So today I want to talk a little bit about BRCA1 and BRCA2 and some of the cancers that can be connected to BRCA1 and BRCA2. I put stomach cancer in there and I didn't add any slides connected to that. Maybe we could talk a little bit about that in the Q&A afterwards. But my focus is going to be on prostate, breast, pancreas, and a little bit on melanoma. I'm trying to prioritize the amount of time on each subject related to the risk associated with each of these conditions. Before we get into any of that, the BRCA gene. So these genes became kind of household names for genes. Not too long after Angelina Jolie wrote an opinion piece in Time magazine. And in that opinion piece, she talked about her experience as being a BRCA1 carrier and having both breasts removed and reconstructive surgery thereafter to reduce her risk for breast cancer. And this is identified because her mother was diagnosed with ovarian cancer, and that's what the BRCA1 gene was identified. And then through the inheritance of these genes, there's a 50% chance that the gene mutation gets passed on. Angelina Jolie inherited that. So she had these preventive surgeries before getting cancer. So people would call her a previver. So this other person's not as well known, but also famous. He's Beyonce Knowles' father, Matthew Knowles. And the reason why he gets brought up is because he was actually diagnosed with breast cancer. How genetic testing was found to have a BRCA2 gene mutation. Beyonce and Solange, his daughters, did not inherit this gene mutation. Again, it's a 50-50, and they were on the other end of the coin flip there in terms of whether they inherited this. But it brings some light to the attention about BRCA1 and BRCA2. This other person who I have here is an individual called Mary Claire King. She was pivotal in the discovery of the the identification of the BRCA1 and BRCA2 genes related to inherited cancer risk. And so I guess this plays a little bit into the story of BRCA1 and BRCA2. Angelina Jolie, famous, really talked about it. No one really knew about Matthew Knowles, didn't really make it to the media. And that kind of concept of media attention really translates into genetic testing in general. And so there's a really nice opinion piece, not in the Time magazine, but instead in another journal called Nature, where one of the people who worked under Mary Claire King, his name is Colin Pritchard, he wrote an opinion piece saying, hey, we're seeing a strong difference in the amount of women being tested for BRCA compared to men. It's more than 10 times higher rate of women getting tested than men. And he postulated maybe it's because it's called BRCA1 and BRCA2. BR stands for breast, CA stands for cancer. These were the first things that came to mind in family histories when these genes were identified. And then later we realized, oh, there's an ovarian cancer connection. And then later we realized, there's a prostate cancer connection. And then we learned about the pancreatic cancer connection. And he said, well, we're calling it hereditary breast ovarian cancer. Men don't have ovaries. Men have very little breast tissue. A lot of men don't even know they have breast tissue. We're very gendered in how we're calling this gene. Why don't we name it after the person who discovered the gene? We did this with other genetic conditions as well. So he said, why don't we call it King syndrome? After Mary Claire King. And it's a funny thing because that's also kind of a gendered way of talking about a genetic condition, calling it King syndrome. But it might be a bad idea to take away the breast and ovary components to BRCA1, BRCA2, because we know that it's more than that. There's also the prostate pancreas story. So let's go into a little bit about the prostate. I think I'm kind of preaching to the choir here. However, when we get into the nitty gritty and you start seeing slides of prostates and penises and bums, those are things that we tend not to look at or pay attention to when we think about the context of the prostate. But all that stuff's kind of important. So the prostate is a gland, and it produces PSA. That's its main job. A gland is usually spongy tissue. And what happens is when that gland, the prostate gland, contracts, it releases PSA at higher rates. But also that prostate will just generally produce a steady state amount of PSA. PSA's job is to liquefy liquefy semen and nourish sperm. So when the prostate contracts after an ejaculation, the PSA is getting mixed in with the sperm and the semen and kind of doing its job at that point in time. When the prostate is just hanging out doing its thing, it's still generating PSA, and that PSA leaks into the blood system at a steady rate that we can measure. For guys, there's 3 parts of a man's body that continue to grow as he ages: his nose, his ears, and his prostate. And so as the prostate gets bigger, it takes up space. And where does the prostate live? Right below the bladder. And the tube that goes through the prostate is the tube, the urethra that you pee out of. And so some guys, as they get older, a lot of guys, as they get older, start having what are called lower urinary tract symptoms that can include things like peeing more frequently, having to pee urgently. Once you finish peeing, you don't feel like you fully evacuated your bladder. When you pee, it used to be this nice little spiral, and then it starts to fan out a little bit. That's all part of the guy's guide to being a guy that no one ever was told that they could read. And so this is a normal part of aging for men, but a lot of guys say, hey, my prostate's doing something weird. And that might be the first time that they think about going to a urologist and getting a PSA test. One thing I'd like to show here is all of the different nerves that are connected and surrounded by the prostate. There are nerves that are connected to erections, and there are nerves that are connected to being able to hold in pee that are entwined around with the prostate. Prostate cancer is really common. There are studies that people, when I talk about prostate cancer, people say, hey, doesn't 80% of guys have prostate cancer? And one study showed, and it was a really well done study, that looked at people who died from cardiovascular disease or motor vehicle accidents, and they did autopsies on those men and looked to see how many of them had prostate cancer. And they found that 80% of men who were 80 years old had prostate cancer. Having said that, we quote that the general population risk is only 11 to 12%. Now, those two pieces of information, 80% of men have prostate cancer by age 80, and the lifetime risk is 11 to 12%, are both true. And the reason why we discovered that 80% of men have prostate cancer is because we went looking. This probably a lot of these guys never needed to know that they had prostate cancer, or because they had very low grade prostate cancer. The stereotype with prostate cancer is that most men die with their prostate cancer, not because of their prostate cancer. And it's earned that stereotype. But there's definitely deviations to that rule. The general population risk are people who have been screened and who have been identified to have prostate cancer. And that's a lower group of people. And these numbers will fluctuate from country to country based off of the prostate cancer screening protocols of those countries. For the Canadian experience, it's 11 to 12% lifetime risk for prostate cancer. The genes BRCA1 and BRCA2, if there is a genetic mistake, we call these, technically they're called variants within the gene. Lots of genes have, most people have variants in their genes. It's only if the variant that's identified is actually causing a medical problem Those are the ones that we care about. We call those pathogenic variants. We interchange that word with the word mutation. But if you get a genetic test result, it'll say pathogenic variant. So I'd like people to know about that language in case they're looking at their own records. But I'll call them mutations going forward. So if someone has a BRCA1 or BRCA2 mutation, their lifetime risk for prostate cancer elevates. For BRCA1, it goes up to about 26%. For BRCA2, it goes up to about 61% lifetime risk. I'm going to reference this other thing here called the NCCN, which is an American national guideline that we follow loosely. Provinces have their own kind of opinions on how things are screened and what different rates are, but a kind of a northern guidance for a lot of clinicians is the NCCN recommendations. So how does prostate screening look? The first one is the DRE. So we'll call that Dr. Dre is what we say in our clinic as a bit of a joke. But it stands for digit, being finger, rectal examination, digital rectal examination, DRE. And this is basically just feeling the prostate for any lumps or bumps. Cancer tends to have a very different consistency than the glandular sponge-like tissue of the prostate. And so doctors can feel that there's any abnormal lumps or bumps in the prostate, but physicians can't feel all the way around the prostate, just a piece of it. And so it's not the best screening tool. It can miss a lot of prostate cancer. Having said that, it's free. It takes a few seconds to do. And for people who have a hereditary risk, it's probably not a bad idea to have this done on a regular basis in addition to the PSA blood test. Back when Prostate Cancer Canada was a thing, they came up with a campaign called the Famous Finger Collection, where they had these different types of famous hands, gloves that the doctors could put on to kind of make light of the of having a digital rectal examination. Guys tend to approach something that's uncomfortable, or sometimes even talking about medicine with a degree of humor, and I think that this highlights a popular way of humorizing something like a digital rectal examination. As we talked about before, prostate screening can also involve the PSA blood test. And this is when this PSA, which stands for prostate-specific antigen, leaks into the blood at a steady rate, and we're able to measure whether someone might have an elevated risk for prostate cancer on that. The theory here is that if you have standard growing prostate cells, they're creating a standard amount of PSA, so establishing your baseline is really helpful. And if there is rapidly growing cancerous cells within the prostate, we expect there's an elevated amount of PSA being generated. And so when PSA elevates, one of the reasons can be because there's rapidly growing cancerous cells. Having said that, PSAs can elevate for a whole bunch of reasons. One can be that the prostate is getting bigger, which is just part of the guy's guide to being a guy. The other thing that can cause the PSA to elevate is an infection of the prostate called prostatitis. Symptoms of that can be night sweats, can be nothing. It can be pain within the prostate. And so a lot of guys may not know that they have prostatitis. They do a PSA test and their PSA spikes up. And the urologist or the family doctor or the oncologist is not worried about a huge spike in the PSA generally. What they'll want to do is repeat your PSA, maybe give you some antibiotics and see if it goes back down to baseline. False positives, super common in PSA screening. That's why its specificity is actually quite low. And we can talk a little about that in the question and answer period. Another reason for an elevated PSA, a recent ejaculation. Try to avoid ejaculation 24 hours prior to doing a PSA. Physical exam, you're squishing the prostate, that can cause an elevated PSA. Go for a bike ride, motorcycle, riding lawnmower, those can also jostle the prostate, increase risk for a falsely high reading. So how do we approach prostate screening for individuals with BRCA1 or BRCA2 gene mutations? Largely, we group BRCA1 and BRCA2 together when it comes to screening. There's a bit of a deviation here. The risk for prostate cancer in guys with BRCA1 gene mutations is up about 20%. And so although it's elevated, it maybe is not considered a high risk for prostate cancer. I'll let people decide what they think is high, but clinicians don't define this as being a high risk. And so although the risk is elevated, we would recommend that people start doing screening earlier. In my clinic, all guys start at age 40, but some centers might start at 45. And this is fine. In your 40s, we're just doing PSAs to establish a person's baseline. it's incredibly rare for someone to be diagnosed with prostate cancer in their 40s. It can happen, it's just super rare. We're basically setting the stage for a PSA baseline to help people in their 50s, 60s um, um, to get that insight if there's a deviation to their PSA. Remember, with BRCA2, the risk is up to 60%, PSA screening up 40. There's newer evidence to suggest that maybe we should be doing this thing called multiparametric MRI, basically a prostate MRI. We just finished doing a study where we did MRIs on guys in our program, BRCA1, BRCA2, and then we did a random biopsy. And we're going to build some evidence to suggest that maybe MRIs could be a part of the screening program. At what interval, we don't know. But maybe in a few years from now, MRIs might make their way into the screening for the BRCA2 population. This is a little bit of a talk about pathology. There's different scores of prostate cancer. Prostate cancer gets graded after someone has a biopsy. And depending upon the grade that the individual has, there's different treatment options that are available. Treatment options may include things like active surveillance. Active surveillance is doing biopsies, doing PSA tests, doing MRIs on a regular basis. This is for someone who's diagnosed with typically an earlier stage. This is grade group 1, grade group 2, or sometimes grade group 3 disease. And active surveillance is not treatment, it's monitoring, because most men don't get aggressive prostate cancer. There's a study that was done for guys with BRCA1 and BRCA2 mutations. And what they found is that men with BRCA1 and BRCA2 mutations were more likely to have their prostate upgrade from grade group 1 to 2 or 2 to 3 at a higher frequency than people in the general population. This was particularly, and maybe most significantly, true for men with BRCA2 gene mutations. And this follows this theme that men with BRCA2 mutations, their prostate cancer is more likely to become aggressive and deviate from the stereotype of prostate cancer being benign. And so active surveillance may not be the best protocol for individuals with BRCA2 gene mutations, just because they have a higher chance of reclassifying, or maybe the protocol needs to be a little bit different for men with BRCA2 gene mutations. The other option is someone has intermediate risk disease or earlier stage disease, and they have a BRCA2 and they want to get treatment. This is from the Matrix. You have Morpheus here. He's giving the option of the blue pill or the red pill, prostatectomy versus radiation. There's a whole bunch of options for radiation. Prostatectomy is usually robotic or by hand, and that's to have the prostate removed. For BRCA2 mutation carriers, may not be a bad idea. If there's an open discussion about radiation or prostatectomy, maybe having the prostate removed is more advantageous because you could do a full pathology review of the prostate. As opposed to radiation, you can never interact with the prostate. You're just making inferences off of the biopsy only. You also can't assess lymph nodes. Other treatments could be hormone or chemotherapy. Other treatments could be a PARP inhibitor. This is a medication that's specific to people with gene mutations and is used for men who have metastatic prostate cancer. This medication takes advantage of the molecular pathway for BRCA1 and is catered just to people with BRCA gene mutations, as well as ATM mutations. Okay, we're going to pivot on to the breast story. All humans have breast tissue. If you're a human, you have breast tissue. Men, however, and I'll use that term in stating people who are assigned male at birth and who have not had any exogenous or any hormone treatment afterwards. Very few men have breast tissue. However, some breast tissue may develop later in life as well. The breast tissue hangs around the nipple, and if you can feel your own chest, you can feel your nipple. There might be a little bit of a pad there. Then there might be some fat tissue. Then there might be muscle. You can feel past your ribs, and you're feeling past all that tissue. As men age, or if people gain weight, they'll develop something called gynecomastia. Gynecomastia, there's actually two forms. There's pseudogynecomastia for men who have developed some weight and there's fat tissue that's on their chest. And then there's true gynecomastia, where at some point in time there might be an increased rate for hormone, particularly estrogen, that would cause some of the breast tissue that hangs out by the nipple to actually grow. Breast tissue develops in a body where there's more estrogen than androgen or testosterone. Breast tissue stays naive, doesn't do much if it's in an androgen or testosterone dominant body. Hormones within an individual can change. A little bit of difference between the pseudogynecomastia and gynecomastia. Gynecomastia is there's actual breast tissue in the man's chest. Pseudogynecomastia is that it's fat tissue. However, fat tissue can increase estrogen production. And so people who have lots of fat tissue on their chest, if they have it in other parts of their body, they can start producing a higher rate of estrogen and then develop true gynecomastia. Breast cancer risk. In the general population, for men, super low, much less than 1%. For BRCA, it's low still. It's about up to a 1% risk. 99% of guys with BRCA1 gene mutations do not develop breast cancer. For BRCA2, up to 7% lifetime risk. The main thing when it comes to breast cancer is informing men that they can get breast cancer. Step one. Step two, being attentive to parts of breast tissue. Some guys were aware that they had a lump on their nipple for years and just never knew that they could get breast tissue, never talked to their doctor about it. And other guys who know that they have gene mutations, if they ever see a breast lump, they go to their doctor. The first thing on the radar is breast cancer, and they go in for management. So what are things to kind of look out for if someone, for men, when it comes to looking for breast cancer? Oftentimes, breast cancer in men is not painful. It's a lump or a bump, different consistency. It's not squishy tissue. It might be hard, like a pea or rice, dried pea. It could be in the nipple, the brown spot, the areola, chest, armpit. Could be in lymph nodes as well. So looking for anything here. We're looking for redness, scaling, puckering, difference in like a ribbing almost on skin. And then the big ones for the nipple is if the nipple goes inside of the body, or if there's bleeding from the nipple, and it's not because you've run a whole bunch and it's because of chafing. It's an inappropriate form of bleeding. These are all really good indications to go to your doctor and say, hey, I have a gene mutation and I'm experiencing this. First thing on that doctor's radar is breast cancer. I do not have a BRCA mutation. If I presented to my doctor with any of these things, they would say, maybe it could be cancer, but it's likely a few other things before they would get to the thinking about it being cancer. So again, the guidelines for breast cancer screening through this NCCN, this American Association, they say doing self-breast examination, training, education, that can start as early as age 35. Sure, breast cancer in someone's 30s, 40s, super rare, but why not start? There's no harm in being comfortable with what your chest tissue looks like. Sometimes people will be followed by their family doctor to get that breast examination done as well. Mammograms. So this is, we did a study about this called manograms and how people like to kind of talk about this, whether they want to talk about breast tissue or chest tissue or what. Essentially, it's just an x-ray of your chest tissue. We recommend nothing. We have conversations with people to say, hey, if you want to get that done, you can start at age 50. And the frequency with which we do it, it's the Wild West. It comes up to what the person wants and what the doctor is comfortable with doing. I think it's worthwhile having a conversation. I don't think there's any problem with advocating to get a mammogram done if you are 50 or older and have a BRCA2 gene mutation. BRCA1, the risk is 1%. It's super low. Screening with a digital clinical and self-breast examination is actually a really effective screening tool. We may not need to be as involved as doing a mammogram. Having said that, if you have a family history or any other concern, an important thing to kind of have a discussion about. Next thing, the pancreas. Pancreatic cancer is a tough one. It has its own kind of scary story along with the ovarian cancer story. And what makes pancreatic cancer screening so scary is that we're not really good at screening for it. We can't pick pancreatic cancer up early. And oftentimes some of our screening modalities can just completely miss it, and people can be diagnosed, months after having a negative screening examination. And so even if someone does do screening and everything comes back perfectly fine, I would not be, overly reassured by that. Screening can miss a lot of pancreatic cancer. Lifetime risk, about 1% in the general population. For people with BRCA1, up to 5%, BRCA2, 5 to 10%. And so this is tricky information to talk about because people can be at elevated risk and our screening options are quite limited. Now, BC is kind of ahead of the game here. Unlike other provinces, BC offers screening through blood tests called an HbA1c. It's actually a test that we use to screen for diabetes. And there's some evidence to suggest that if people start having a high HbA1c, there could be a connection to a pancreatic cancer. Not the case for most of the time, but it could be some hint to say, hey, maybe we have to look a little bit deeper at this. We're kind of grasping at straws, and there's some evidence to suggest that HbA1c can help us look at the right hay barrels and what straws to look at. So this starts at age 40 every 3 years. In Ontario, we do not offer HbA1c testing for pancreatic cancer. Instead, what we do is we do some of the imaging. Again, BC's ahead of the game here. They'll do endoscopy every other year, and then the gap year, they'll do an MRI. And so every year they're screening, it's just a different mode. MRIs and endoscopic ultrasounds are the two imaging modalities. Endoscopic ultrasounds might be a little bit better. MRI is also useful. And so BC residents will be able to benefit from that. In Ontario, we may offer MRIs selectively. There's no guidelines for that, and we really don't do that much imaging. Endoscopic ultrasounds, it's hard to access for BRCA carriers. This brings us to these other blood tests that look at what's called they look at circulating DNA that's in someone's, that's floating around in someone's blood. And what they're looking at is different fingerprints that live on top of the DNA. And their technology is able to read those fingerprints that live on top of the DNA. And based off of that fingerprint, they're able to identify where the DNA is coming from, what tissue. Is it coming from the prostate? Is it coming from the breast? Is it coming from the pancreas? And they're also able to identify, is the fingerprint suggestive of cancer as well? And so just by doing a blood test, they can say, okay, it looks like this person has a cancerous a fingerprint on some of their DNA, and that we think that it might be coming from this site. And so on the left, I have the CHARM Consortium, which is a research study. Individuals who have BRCA gene mutations are eligible to participate in this. BC Cancer is one of the sites that recruits for this. It's again a research protocol where they're trying to understand whether or not doing something like this, impacts people's health. And so they put people into either a randomized, people are randomized to either being in the intervention arm or the placebo arm. You don't get to decide which one you are. If you're in the intervention arm, you get the screening test. If you're in the placebo arm, you don't. And so a free option for getting access to this type of screening. And there's also a private pay option, which is called Gallery. And this is available in Canada as of October, and it'll be available in BC within a few months. Melanoma. So general population risk about 4%. BRCA1, BRCA2 is increased, difficult to say. Lots of biases in this data. And the other kind of challenging bit to this is that if melanoma risk is increased, we don't do too much differently. In Ontario, at least, no dermatologist will follow someone because they have a BRCA gene mutation. Dermatologists want to know what to look for. And so if someone comes and doesn't have a lesion that looks suspicious on their skin, dermatologists don't want to follow these people regularly. So we'd like to focus on the A, B, C, D, E skin changes that people can kind of monitor themselves or have their partner monitor on their back where they can't see, and also just being sun conscious. Important things kind of in general. Okay, timing wise, I think I did pretty good. So I wanted to have 30 minutes kind of just talking about the main sites that I consider relevant. I kind of skipped the stomach story and I added it, and I should have taken it off the agenda. I was debating whether or not I would talk about it. There might be some evidence suggesting that there could be an elevated risk for stomach cancer. The evidence is just so new that it's difficult for us to make any recommendations at this point in time. One thing we like people to talk to their family doctors about is to rule out a common stomach infection called Helicobacter pylori. And so there are tests that a doctor can do to see whether someone has a Helicobacter pylori infection. And if so, there's treatment to get rid of that infection. The reason why we care about Helicobacter pylori is because this is its own risk factor for stomach cancer. And so Helicobacter pylori, and if there's any potential risk still to be determined related to these genes, we want to make sure that we can just at least reduce any other risk factors at this time. So this is, I think, maybe a nice discussion to have in a year or two from now, to see if there's any kind of new evidence to suggest whether or not this is something that's real, that we have to focus on, or whether this is just a study that came out and that may not have enough applicability to the North American experience.
Great. Thank you, Justin. Wonderful presentation. Very thorough overview of, everything we need to be thinking about around BRCA in men. So thank you for that. And I'll take this opportunity to ask some of my own burning questions, if you don't mind, to follow up on the content you've shared so far.
Yeah.
So just as a general reminder for the session, so I'm going to go through a number of questions, and then we'll open up the floor to all of your questions as we go along. So, some of the questions I had in mind, we've sort of covered as part of your presentation. So we'll, might be a little bit of repeat here, but we'll try to hit some of those main points. So to start, I wondered about just going back to the genetic testing piece. So at the very beginning, thinking about that genetic test, and one thing that you mentioned was that we know testing rates are lower in men compared to genetic testing rates for women. And you mentioned one factor that probably contributes there is the media and sort of the story that we've heard around what the risks are. I wonder if you think there's other things that are contributing to that, or sort of how we might be able to move the needle there.
Yeah, I think it's a really, I think it's a great question. And we actually have a really nice opportunity in this medium right now, with a lot of men who have had genetic testing. I'd be interested to hear some of your stories as to, whether you experienced any barriers, what prevented you from getting testing, or if this was something that, as soon as you heard about it, you jumped on it. If anybody has any kind of unique perspectives on the story, we do studies interviewing you to learn what barriers are, and so maybe in the last few minutes we can talk about whether people have experienced any barriers, or whether or not this is just an easy part of their clinical path, or they had a family member who had this and they just immediately went on to do testing. People talk about, for guys. Very pragmatically, men have had much less exposure to the healthcare system. Men have not been getting cervical screening earlier on in life, and haven't had frequent visits to the doctor talking about contraceptives early in life. And so sometimes men's first experience with the healthcare is in their late 30s or 40s, whereas women might be experiencing, their first visits to healthcare when they're 12. And that comfort with the healthcare system can maybe sometimes inform people's opinion to be more proactive with their health. Theory one. Theory two, some people think that, going to the hospital and caring about your health is maybe demasculating. Tough guys don't go to see the doctor. They'll just figure it out. And so there might be that kind of a gendering piece to hospital visits. And so these are people who are making up, not making up, who are hearing people's feedback and implementing these theories. So these are kind of the general answers to those questions, but I'd be interested to hear if anybody has any other kind of thoughts, or what their personal experiences might be in a bit.
Great, thank you. And one thing I noticed a real common thread through your talk and this answer here today is all the research that's going on in this area. It sounds like we're going to have a lot of really exciting, new research and data coming out. And this is another question that I think is important to hear from, people in this group here as well, and try to figure this question out. So if you were talking to a man who is unsure, maybe if they want to have a genetic test or not, and is making that decision, I wonder sort of what that kind of conversation might look like for you about sort of weighing those pros and cons, or what you might say to them. A couple common things that we hear often are, concerns about, do I need to have this genetic test? Or also concerns about what this might mean for things like insurance or employment. So, yeah, curious on your take on that.
Yeah, yeah. And so, I mean, the gene doesn't care whether or not it's living in the body of a man or a woman. It's going to do its thing. And if someone has a mutation in that gene, it's still going to be increasing risk for certain cancers. Now, here's a way that I kind of approach things. Most men with BRCA1 mutations, most men do not get cancer. Most um, um, men with BRCA2 mutations have a much higher rate of getting cancer. And so some guys say, hey, I have a BRCA1. You just told me that a lot of guys with BRCA1 don't get cancer. Why would I do this? It just changes your access to screening services. It makes me think a little bit about the pancreas story, makes me think about the prostate story, and for an individual to be on top of that. Um, and so there's that component. Another big factor, and a lot of what I hear motivates people to get testing done is for the next generation, particularly if they have daughters. And a lot of guys say, hey, I'm doing this for my daughter. And I turn that back and I say, I get that. I understand that, but you need to be around for your daughter. You're doing this for you too. And by doing it for her, you're also doing it for you. And so a lot of guys come into the testing with altruism. This is for other family members. But if a man only has sons, I would still argue that there's good applicability. You want to be around for your sons, and if there's access to screening that you can get this test. See if you are eligible to get more access to screening. And as we learn more, you might get more access to screening. To answer the other question about insurance, we have the Genetic Non-Discrimination Act. This was enacted in 2017. It prevents life insurance, critical illness insurance companies from accessing your genetic test results. One caveat to this is that the insurance companies can still access your family history and use that against you. And another kind of nuance to this is that if I find that you have a gene that's increasing risk for cancer, that medical record is not accessible to insurance. But if I then refer you to a high-risk prostate clinic, insurance companies can access the fact that you're at a high-risk prostate clinic, and they can say, hey, you have no family history of prostate cancer. Your PSAs look great. Why are you being followed by a high-risk prostate clinic? And they could use that information against you. So there is protections, but they're not full. They're really good, particularly compared to our southern neighbors.
Great, thank you. All right, pivoting a bit over to the breast cancer question, and I won't spend a lot of time on breast cancer. I'm going to move on to some of the other ones, but you mentioned some of the things to watch for, and this is a common question that comes up for me in clinic is sort of how to do a breast exam. A lot of the resources, if you Google, are very focused on female breast exams and sort of what to look for there. You mentioned some of those things. I'm wondering if you know of any resources out there specific to this kind of information for men.
Yeah. So, very interestingly, if you YouTube it, YouTube breast examination, a male breast examination, there will be men who go through the motions of how to do it. This is not rocket science. It's something that family doctors will do, and they will teach you how to do it. You're feeling for consistency differences in the nipple, the areola. And you're feeling for consistency differences in the armpit. This is where some of the lymph nodes hang out. And from those diagrams that I showed before, all of the breast tissue leads to the nipple. So you start with the nipple, work your way out to the areola. You can feel some type of density difference, and you're looking to feel if there's any kind of consistency difference. Everything should be squishy aside from your ribs. If something's not squishy, you go to your doctor about it.
Right, that's very helpful. Thanks. I want to ask about prostate cancer risk management. You started talking about Angelina Jolie and talking about the preventative surgeries that she had. And we hear a lot about prevention and preventative surgeries for women. I'm wondering if you can talk a little bit about why we don't hear about that for men so much. Those risks for prostate cancer are fairly significant, but you don't hear much about preventive or surgical prevention.
Yeah, so there's a clinical trial that's based out of Toronto by a guy. His name is Oh man, I just was just thinking about it. It's not Finelli. It'll come to me. He does a clinical trial where he does a prostatectomy um, on BRCA2 mutation carriers, and his clinical trial, the theory behind it and how he got RAB approval is because men with BRCA2 mutations are more likely to get aggressive prostate cancer. And if people want to have this prophylactic surgery, why should we, not let that be eligible for them? The difficulty is that it's difficult to prove that having your prostate removed actually, impacted that person's overall uh, um, um, mortality. And so that's a little bit of the controversy behind this clinical trial. Um, there's a doctor in Toronto who will do it if you want to have it done. Having a prostate removed comes with some side effects, and they are all going to be there. It's just to the varying degrees of which they're there, and so informed consent is really important for someone to know exactly what the risks are before having the prostate removed. So I have a different opinion because I know someone who does do prostatectomies for people, and he's probably the only person in North America who does it. Definitely the only person in Canada who does it. There might be people in the US. It's just not very commonly done because prostate screening is very effective if people get it done on a regular basis. B, most prostate cancer, easy to pick up, and oftentimes it's picked up at early stages, and then. The other one is the side effects that are connected to having the prophylactic prostatectomy.
Great, thank you. It'll be interesting to follow that trial and see how it goes. You spoke a little bit
Finelli,
earlier about
no, it's not Finelli. Yeah. Sorry, no, it's not. I'm going to Google his name.
Yeah, great. You spoke a little bit about PSA screening, sort of the specificity, the sensitivity of that screening, and how there are some issues in particular with the specificity there. I'm wondering if there is data you can speak to specific to the sensitivity specificity in BRCA carriers that might be separate from the sort of the general population that's more, I guess, thoroughly studied.
Yeah, so if there is data on there, I'm not privy to it specific to BRCA carriers. Um, um, the PSAs vary based off of age, and based off of age, the PSA thresholds kind of differ. We suspect it has a very similar course. Specificity is when the ability for a test to correctly identify someone who does not have the thing that they're looking for. And so you want the specificity to be super high. You want a lot of the people who have you want to identify, you want to make sure that people are not being incorrectly identified. For PSA, the specificity is 10%. It's not really that good. And a lot of the reasons that we mentioned before, prostatitis, the infection, the benign prostatic hyperplasia, the growing of the prostate, all these things get interfered with the PSA test. So it's not the most reliable test in the world. The sensitivity is the ability for the test to pick up people who have prostate cancer. And the sensitivity is quite significant. It's about 90%. So it's a sensitive test. It does a good job in detecting prostate cancer. It's just bad. The false positive rate is actually quite high with this one. And so it's a finicky test, but you just need a doctor who's used to ordering it, knows the nuances, and can help counsel an individual on false positives and help that person anticipate the fact that false positives are very likely if someone gets PSAs over the course of their life. And not to be too worried about them. The doctor who's ordering the PSA test will tell you when to be worried, but if you have a spike in your PSA, that might not be the time to be worried. So sensitivity, 90%, specificity, 10%.
Great, thank you. And sort of following up on that, and I'm less familiar with the situation in Ontario, but here in BC, PSA is not covered by our MSP coverage for asymptomatic men. I'm wondering if you know about sort of efforts to advocate for this kind of coverage, maybe targeted to the BRCA population, or yeah, where is that sort of sitting at the moment, if you have some
Yeah,
information on that.
yeah, province to province, and I think that it's a very reasonable thing to advocate for. We're stuck though because the Canadian Preventive Task Force has recommended against PSA screening, and those recommendations were made back in 2014. They haven't been updated in 12 years, which is crazy. These should be updated much more regularly. And so they're using data from 2014. And the way that we approach prostate cancer back in 2014 is completely different now. For example, active surveillance is a very commonly done management tool for prostate cancer. And it really defies a lot of the reasons why PSA should not be implemented on a regular basis. There's two big studies that came out. One of them, an American study, another one, a European study. And basically what they did is they monitored people with PSA. And in order to implement a program in a national program, you have to prove that the intervention, in this case, a PSA test, is going to save people's lives, A, and B, it's not going to cause a lot of problems. And the sum of these studies showed that PSAs might be causing more problems, identifying really early stage prostate cancer, leading to lots of side effects in people. And these men were going to die with their prostate cancer. It was never going to impact their life. So you've just treated a bunch of guys, given them all these side effects, and they were going to pass away because of a heart attack, anyways. And so a lot of these governments are saying, why are we doing this? Why are we picking up prostate cancer? They're ignoring the 10% of men who are picked up with prostate cancer that's really aggressive. And when you're looking at things in a public health perspective, you're weighing out the 90% versus the 10% when we're implementing screening. The European studies show that the mortality is PSA does save lives, and it does cause side effects, but it saves more lives than it causes side effects. And so lots of Europeans do. European countries will cover PSA testing. The data from the U.S. is also flawed, and because of the protocols and breaches of protocols that were done in that study. Anyway, so long story short, it is a fee for you do have to pay for it. In each province, you can justify that someone who has a genetic mutation is at elevated risk, like someone who has a family history, and should therefore, there should always be a suspicion that the person has prostate cancer. Therefore, they should always be getting PSA covered. Sometimes, depending upon where you go, your doctor, if you're being followed by a specialist like an art clinic, we cover it, but we just cover it because we're in a research program. Most people have to pay for it, particularly if they're not being seen by a big hospital. So to advocate, I don't know. You advocate for the guidelines by the physicians to update their opinion from 2014.
Thank you. So it sounds like it's a pretty similar situation, sort of across the board.
Yeah.
Yeah. All right. I'm gonna switch topics to the pancreas. So as you mentioned, this is one that is a really tricky cancer to detect early, tricky to screen for. I'm wondering if there are some actions that can be taken to reduce the risk, or what can people do to help manage this, manage their risk outside of screening?
Pancreatic cancer?
Mhm.
Yeah. I don't know. General cancer prevention risk. Increase vegetables, fiber, perhaps decrease red meat, exercise regularly. Those are my kind of cancer general things. Focus on sleep, prioritizing sleep, consistency being key. So basically, heart health, diet, and Alzheimer's prevention. And cancer prevention, all those things kind of tie into each other nicely. I don't know if you have any other insight, Melanie. BC tends to be experts when it comes to, or more advanced when it comes to the pancreatic story than us in Ontario, at least.
I'll throw in two more, which are just avoid smoking and limit alcohol. So I'll throw those into the mix. Smoking in particular does have a pretty strong connection with pancreatic cancer. So avoiding smoking is a really helpful step to take. Yeah, so just two more, which again, aren't going to be shocking to anybody. But those general things that can help manage your risk. And you mentioned screening a little bit. I'm wondering, and I can comment if needed on sort of the situation in BC, but in your clinic or sort of where you follow, which BRCA 1 or 2 carriers specifically are you sort of focusing on for thinking about pancreatic screening?
Yeah, pancreatic screening, we're focusing on people who have a family history. We're focusing more on BRCA2 carriers than BRCA1 carriers. And so family history for us is a bit of a predictor. Whether, if we have to pick anybody to be accessing our limited services, we would we would favor someone who has a family history just in case there's something else genetic going on in addition to that BRCA or gene, or if that BRCA gene mutation is in a region that's just more pancreatic cancer connected. We don't really know, and so that would be a factor.
Great, thank you. And yeah, top of my list as well is thinking about that family history, in addition to the genes. So in particular for BRCA2 and people that have a close relative with pancreatic cancer being like a parent, sibling, or a little bit further like aunt, uncle, grandparent would be kind of our main focus there. So I think I'm getting towards the end of the questions I had prepared for today. Was there anything else that you wanted to add that we haven't sort of covered in our chat so far? And then we'll open up the floor to questions from the audience.
No, happy to open it up. I will say that when a genetics person says that we rely on family history, it's our cute way of saying we don't really know what's going on, and we think that there's something else going on. And family history is our guiding light, and so it's us kind of humbly saying genetics is very complex. We can look at one thing, but there's probably other things at play as well that we just might not know enough about. If I could
Absolutely.
speak on
Thank
behalf
you.
of us.
Sure. Yeah. Yeah, absolutely. Um, Great. Well, I think we'll maybe end the recording, and then we'll open up the to the floor for questions.